My name is Elena, and I am the nurse taking care of Austin James. Austin James, an 18-year-old Caucasian female with no previous medical history, was brought to the emergency department by her mother due to lethargy and altered mental status. The patient complained of a stomach virus for the past several days and claimed to have eaten and drank very little. Other complaints included unusual hunger and thirst, getting up several times throughout the night to urinate, and losing 10 pounds over the last month without trying. The patient presented with a fruity scent to her breath. The patient's current vital signs indicate reflex tachycardia, hypotension, and Kussmaul's respirations, which is deep and labored breathing. The reflex tachycardia is the body's response to an extreme drop in blood pressure. Kussmaul's respirations reflect the body's effort to blow off CO2, and hypotension reflects a drop in blood volume. Her skin is intact. Mucous membranes are dry and her skin turgor is poor. She is sluggish, oriented to person, moves all extremities, but follows commands sporadically. Her pupils are equal and reactive to light. Her lungs are clear to auscultation throughout. S1 and S2 are present. There is no edema present. Her abdomen is tender to palpation, and bowel sounds are active in all four quadrants. She has voided dilute and clear urine to fully, averaging 200 milliliters per hour. The patient has 2 large bore IVs, one to each antecubital. Initial lab work revealed a blood glucose level of 521, indicating extreme hyperglycemia. Arterial blood gases revealed a pH of 7.24, CO2 of 28, and bicarb of 12. The anion gap of 18 indicates metabolic acidosis. The patient was given a 10-unit bolus of regular insulin IV push and started on 0.1 units per kilogram per hour drip. The patient was admitted to the ICU medical surgical unit with a diagnosis of diabetic ketoacidosis, or DKA, due to onset of type 1 diabetes. In type 1 diabetes, the patient's pancreas is unable to produce enough insulin to utilize the glucose in her body. Therefore, the patient's blood glucose level will be elevated.
How does my daughter have type 1 diabetes?
Hey, I have 2 sisters with type 1 diabetes.
An extreme complication of untreated diabetes, DKA, begins when the body cannot process glucose due to a lack of insulin from the pancreas. Without insulin, glucose can't enter the cells and it accumulates in the bloodstream. Because the cells are not receiving energy or glucose, they send starvation signals to the body. Thus, the body begins to break down fat. The byproduct of fat metabolism, acidic ketones, build up in the bloodstream, causing ketoacidosis. The acidic state can be fatal due to heart rhythm abnormalities. The kidneys attempt to fix the problem by flushing out the excess ketones and glucose with water and urine. The loss of water leads to dehydration, which continually worsens the acidic state. The body attempts to flush out the acidic compounds, which may lead to hypovolemic shock. Her lab revealed that her hematocrit value was 56. Her hemoglobin was 15.5. Her white blood cell count was 11.9. Lactic acid in her blood was 12, and serum osmolality was 329. Both urine ketones and serum ketones were positive, which is abnormal. Her sodium was 130, potassium 5.4, chloride was 100, her CO2 level was 33, her glucose was 78, her BUN was 44, and creatinine was 0.7. The elevated BUN-creatinine ratio of 63 reveals dehydration. The amount of glucose in her bloodstream has exceeded the kidney's ability to reabsorb it. The body flushes out the excess sugar with water, leading to dehydration. The patient's sodium level is slightly low because as the body tries to compensate for the acidic state, it exchanges potassium for hydrogen ions in the form of water. As the body pumps out water, the salt is carried, resulting in hyponatremia. The provider ordered
titrate O2 to maintain SpO2 greater than 92%. This is a standard order in the ICU to ensure adequate oxygenation of the body. Vital signs to be taken every hour. Patient is NPO until anion gap is normalized. The anion gap is due to the metabolic acidosis caused by DKA. The patient is NPO while in DKA because she is in extreme hypoglycemic state and eating would exacerbate this problem. Once the anion gap is closed, you know the patient is no longer in metabolic acidosis or DKA. The patient presented with lethargy related to DKA and was inconsistently following commands upon admission, so NPO may have been ordered to prevent incomplete swallowing or aspiration. Once her anion gap is normalized and she is out of DKA, her mental status should improve. When that happens, she is a better candidate for oral intake. Check blood glucose every hour. Check plasma glucose if it's above 499. Blood sugar should be checked every hour to ensure improvement. However, normal blood glucometers cannot read above 499, so we would check her plasma glucose if at that level. If blood glucose doesn't fall by 50 to 75 milligrams per deciliter per hour, then double insulin hourly until that rate is reached. The goal is to increase uptake of glucose into the cells and decrease the blood levels quickly so the body stops receiving starvation signals from the cells. Thus, the body will stop the breakdown of its own fats and proteins and halt production of acidic ketones as a byproduct. Notify provider if blood glucose is less than 100 or greater than 300. If her blood glucose is less than 100, she has gone into a hypoglycemic state. If the blood glucose is above 300, then she is once again hyperglycemic despite the prescribed insulin dosage. In both situations, the provider should be notified to determine what changes in care should be implemented. When blood glucose is less than 250, change fluids to dextrose 5% and 0.45% sodium chloride at 200 milliliters per hour. Maintaining the patient's fluid balance is a delicate process which is critical to recovery of the patient. 5% dextrose, D5W, is an isotonic solution that supplies sugar to her body at a slow and steady rate. The insulin acts on this sugar and brings it into the cells. This is coupled with a 0.45% sodium chloride or half normal saline, a hypotonic solution that provides sodium and free water. Because D5W does not contain any sodium, it will continue to dilute the amount of sodium in the body. This may result in a hyponatremic encephalopathy if not supplemented with a sodium solution, so it is coupled with half normal saline. Also, as insulin sends glucose into the cell with potassium, it pumps out sodium, increasing the blood sodium concentration. Because the sodium solution is hypotonic, it will push excess sodium into the urine, preventing hypernatremia. Draw potassium level every 4 hours. The patient's original labs indicate high potassium levels as a result of the body's effort to compensate for a prolonged acidic state. However, as insulin pumps glucose into the cell, potassium is taken with it, so blood concentration of potassium will decrease. The patient's blood potassium levels should be monitored for hypokalemia. Hold infusions containing potassium chloride if urine output is less than 30 milliliters per hour or if serum potassium is greater than 5. If her urine output is low, she will not effectively excrete excess potassium. Thus, hyperkalemia may occur if her body cannot use this regulatory mechanism. A potassium level greater than 5 indicates hyperkalemia. Thus, any infusions with potassium chloride are withheld to prevent a hyperkalemic state which could cause cardiac dysrhythmias. If potassium level is less than 3.3, give 40 milliequivalents potassium chloride over 4 hours. If 3.3 to 5, give 20 milliequivalents potassium chloride over 2 hours. Insulin increases uptake of potassium into the cells with glucose, so blood potassium concentration will decrease. If the blood level of potassium is too low, it may cause some muscular weakness, fatigue, muscle cramps, and constipation. If severe, it may lead to flaccid paralysis, tetany, hyporeflexia, and even rhabdomyolysis. If the potassium is less than 3.3, the patient is now in a hypokalemic state and a higher dose of potassium is needed. However, The dose should be administered at the same low, slow rate because a large increase in concentration of potassium in the blood may cause fatal cardiac dysrhythmias. Start 1800 kilocalorie ADA diet when plasma glucose is less than 200, anion gap is closed, and oral intake is tolerated. As previously stated, the anion gap closing indicates that the patient is out of DKA. The patient tolerates oral intake when her mental status has improved and her ability to swallow properly is restored. Once her plasma glucose is under 200, she is ready for intake of food. The patient's blood glucose level should not decrease much further before reintroducing food. The patient's body is used to running at a high glucose level, so food may be reintroduced with a higher glucose so as not to send her body into shock. In later treatment, the patient's body will acclimate to functioning at a lower glucose level with insulin therapy. Stop IV insulin 60 minutes after aspart insulin injection. This allows the aspart insulin, a rapid-acting insulin, to reach a peak before the IV insulin is discontinued. The IV insulin, since it's released directly into her bloodstream, does not have a traditional peak and will only act as long as it is infused. Therefore, once the IV infusion is discontinued, this insulin will no longer affect the body.
Patient was prescribed mixed insulin therapy, which included Detamir twice a day and regular insulin before each meal. Her hemoglobin A1C goal is to keep it less than 6%. The patient is on a mixed therapy because the normal human body has a baseline amount of insulin in the blood, producing more during times of intake. Detamir is a long-acting insulin, which provides her baseline levels. The regular insulin mimics the body's increase in production after meal times. Regular insulin is administered before meals to allow enough time for the medication to begin its effects before the blood glucose rises. Her A1C goal is below 6%, which is within normal range. The A1C measures her 3-month blood glucose level, and we want to see a good maintenance of her blood sugar.
Austin James was discharged home with her parents and a prescription for insulin therapy and diet control. If she eats well, exercises regularly, and carefully monitors her blood glucose level, then she may live her life relatively free of complications. However, uncontrolled diabetes can lead to nephropathy, neuropathy, pressure ulcers, diabetic retinopathy, and an increased risk of cardiovascular disease. It is imperative that she visits her healthcare provider at least once a year to monitor for complications. She must also stick to her medication regimen and carefully monitor her blood glucose level to prevent potentially fatal complications.